We're now going to discuss other cardiac pathology. These are things that are not congenital heart diseases. And one of them is infective endocarditis. You need to know what germs, what bacteria are causative organisms. Strep viridans and Staph aureus. These are the most common causes of endocarditis. Also, in children, endocarditis is usually secondary to congenital heart disease. So look for a high outflow lesion. Something that has very fast flow, like, for example, a VSD or bicuspid aortic valves, things like that. An ASD is a low flow lesion, was not really a high risk for endocarditis. Also in pediatrics, usually there's, besides this underlying congenital heart disease, there's usually another trigger, such as a surgical procedure or a dental procedure, and that's why we talk about endocarditis prophylaxis. Typically, these patients will present with high, prolonged fevers. When we talk about fever of unknown origin, this is one of them. It can cause fevers for long periods of time before it's diagnosed. They may have weight loss or other symptoms. Sometimes you will hear a new murmur, because what happens is you have vegetations developing on the valves, and then that will cause differences in flow, and you will hear a new murmur, or the murmur that's already been there. If you have a cardiac lesion pre-existing, then the murmur might change in quality simply because of the vegetations. Other findings include thromboembolic phenomenon, like Osler's nodes, Janeway lesions, and splinter hemorrhages, which we'll show shortly. Here we have a splinter hemorrhage. These are all thromboembolic lesions. Osler's nodes are going to be these reddish areas on the pads, on the finger pads, for example. And here we have some thromboembolic phenomenon on the feet and even on the eyelids. These are all from endocarditis. The best test is a positive blood culture. You can get an echo and you can see vegetations, but you really are going to have high fevers, and the best test to make your diagnosis is going to be a positive blood culture, strep viridans or Staph aureus. And obviously on physical exam you'll see these other embolic phenomenon that we just showed you. Complications of endocarditis can include heart failure from insufficiency of the valves, particularly the aortic and mitral valves. Remember that the mitral valve is the most commonly affected valve with endocarditis, followed by the aortic and then the tricuspid. You can also have emboli depending upon where the vegetations are. If they're on the right side of the heart, the vegetations will go to the lungs and cause pulmonary embolisms. If they are on the left side of the heart, those emboli will go out to the systemic circulation. Also, endocarditis can cause abscesses and myocarditis. Certainly, it can cause a valve obstruction from the vegetations and can cause heart block. So a variety of complications with endocarditis. The treatment of endocarditis is antibiotics, long-term antibiotics, at least 4 to 6 weeks. And if they're in heart failure, you treat the heart failure with the standard medications. Severe disease may require surgery on the valves, and certainly patients who are at risk for endocarditis require prophylaxis. So patients that have high outflow lesions, again, such as a aortic stenosis or a VSD or bicuspid aortic valves, those are the kind of patients that require antibiotic prophylaxis before any surgical procedure or even dental procedures and even genitourinary procedures. We're now going to discuss acute rheumatic fever, very high yield topic. We already discussed strep throat, and we said that complications of strep throat included rheumatic fever. So look for a patient that has had a sore throat in the past few weeks and now presents with certain signs and symptoms when you're reading the test question. It is the most common form of acquired heart disease worldwide, and the peak incidence is around 5 to 15 years of age. That shouldn't surprise you because we talked about strep throat earlier, and we said that the peak age for strep throat is about 5 to 10 years of age. So it makes complete sense that the peak age of incidence for rheumatic fever, being a post-streptococcal disease, is also around the peak age for the strep throat. Patients can have recurrences of rheumatic fever, and it is an immune-mediated disease. When you're studying for the test and when you're reading the test question, you absolutely, positively need to know your Jones criteria. As you're reading the test question, they will be giving you some of the Jones criteria. You'll be clicking them off in your head, and then you can say, this is rheumatic fever. I need to go answer the question. You need to have evidence of a preceding strep infection. That would be a throat culture, throat swab with a rapid strep screen, or elevated anti-streptolysin O titers. And then you need to have two major criteria. If you have two major criteria, you have rheumatic fever. Or you can have one major criteria plus two minor criteria. And that's why you need to know the criteria so that you can be reading them during the stem of the question. Also, if the patient has chorea in and of itself, by itself, that is enough to make the diagnosis of rheumatic fever. Or if you've had carditis for several months after an initial presentation, that is also it. But for the test, you really ought to just know your Jones criteria. So here we have the Jones criteria, the major and the minor. And a nice mnemonic for Jones criteria is Jones. The migratory polyarthritis, that's the J, joints. O, use your imagination now. The O can be made to look like a heart, and that's for carditis. Erythema marginatum is the E, and that's the characteristic rash that you'll see with rheumatic fever. Subcutaneous nodules provides the N. They can occur anywhere. And Sydenham's chorea, which are those characteristic movements of the body, is the S. So if you have two of those, forget about it. You've got rheumatic fever. Go and answer the question. If you have one of those, then you must have two of the minor criteria. And don't forget, you must have evidence of a preceding strep infection. The minor criteria are arthralgia, fever, increased acute phase reactants like elevated sed rate, and a long PR interval or EKG evidence. Remember, if arthritis is one of your major criteria, you cannot use arthralgia as a minor criteria. That's like double dipping. You can't use it twice because arthritis also gives us arthralgia. So if arthritis is a major, then you need to look for something other than arthralgia as a minor criteria. You absolutely, positively need to know the Jones criteria because it is a clinical diagnosis. Treatment of rheumatic fever includes some bed rest and monitoring. Certainly we need to treat with penicillin because you want to eliminate that strain that causes the rheumatic fever. And then anti-inflammatories, specifically you can use aspirin for the arthritis. And if they don't have congestive heart failure, it can also be used for the carditis. However, if they have congestive heart failure and carditis, then prednisone is a better drug. These patients can go into heart failure because of the valvular disease, so they would need to treat the heart failure with standard medications. Phenobarbital is used only if the patient has Sydenham's chorea. Prevention of rheumatic fever is more important, and that would be prophylaxis with antibiotics. Remember, that's why we treat strep throat, but once a patient has rheumatic fever, you also want to keep them on antibiotic prophylaxis, and that can be given by mouth. We're now going to discuss hypertrophic cardiomyopathy. Kind of mentioned it in the first chapter when we talked about infants of diabetic mothers having a hypertrophic cardiomyopathy. But there are other causes. Any obstructive left-sided lesion can cause a hypertrophic cardiomyopathy. So you can be congenital. Don't forget the glycogen storage diseases, and certainly idiopathic hypertrophic subaortic stenosis is a cause of a hypertrophic cardiomyopathy. The left ventricle is pumping against a huge resistance, and so it does hypertrophy. When the heart gets big, then the left ventricle doesn't fill as well, and you can also have mitral insufficiency because the valve doesn't approximate as well because of the enlarged ring. Patients can have weakness or fatigue. They can complain of palpitations, and they can actually have sudden death, particularly when they have to do some kind of exertion and the heart cannot meet the demands. You can have a left ventricular lift, and you can hear a systolic ejection murmur along the left sternal edge, which is worse with exercise, Valsalva, and on standing, just because of different flows. Again, the definitive diagnosis is going to be doing an echocardiogram, but an EKG will show left ventricular hypertrophy and some strain with ST depression and T-wave inversions. A chest X-ray may show some mild cardiomegaly. These patients, you do not want them to do competitive sports or strenuous exercise, because that's when they can have syncope or they can have sudden cardiac deaths. Again, you also don't want to treat them with inotropes because that puts an undue strain on the heart, and you should use beta blockers for these patients. Myocarditis can be caused by a variety of predisposing factors. Viruses can be one cause, but there are a variety of different reasons why a patient can get myocarditis. The most common viral cause is going to be a Coxsackie B. Also, adenovirus is a common cause of myocarditis. You can get titers for these, which will help you in your diagnosis. These patients will go into heart failure. They can have arrhythmias. It can be an acute fulminant event, or it can be an insidious presentation. In infants, it's usually an acute presentation. In children, it can be acute but less fulminant. And in older children, sometimes it can be fairly asymptomatic, but then the patient can present with a dilated cardiomyopathy subsequent to this myocarditis that was unrecognized. Look for fever, look for a large heart, and look for arrhythmias. Some labs will show an increased SED rate. This is a nonspecific test. It's not pathognomonic. You can also have your isoenzymes elevated. Again, not pathognomonic. The best test is going to be a biopsy. So on the exam, if you are pushed for it, you should do a myocardial biopsy. This will show you histopathology suggestive of myocarditis. You can do an echocardiogram, and you can see a poorly functioning ventricle, and you can also sometimes see some effusion around the heart. Chest X-rays show cardiomegaly, and your EKG can show tachycardia or other arrhythmias. The treatment of myocarditis is to treat the congestive heart failure. The patients that have the acute fulminant, sometimes if you can get them over it, they will get better. Otherwise, they will progress to require heart transplantation. This is a patient with myocarditis. You can see a very enlarged globular heart. This is heart failure secondary to the myocarditis. Endocardial fibroelastosis. There's primary and secondary categories for this. The primary endocardial fibroelastosis, there's no predisposing factor. Secondary means that there is something that predisposed. Usually it's an obstructive lesion in the heart which causes this entity. Typically on pathology specimens, you will see this really thick, white, fibrous endocardium. It's very thick, so it restricts the contractility of the heart, and it can lead to heart failure. It can sometimes actually involve the valves. The diagnosis can be made on echocardiogram and also biopsy. Majority of patients will die in 1 to 6 months if they don't find a transplant heart. The chest X-ray, again, is consistent with a big heart. The patient will be in heart failure, so you'll find those findings also in the chest X-ray. And the echo will show a very bright endocardial surface and a poorly functioning left ventricle. And again, you treat the heart failure, and you treat, the definitive treatment would be heart transplantation. Be suspicious in a patient that has an obstructive lesion and presents in heart failure. Hypertension. Typically, we like to think of hypertension as a cardiac problem, although in pediatrics, you should always think of hypertension as a renal problem. Routine blood pressure checks start at around 3 years of age when they come in for their regular routine health supervision visits. Obviously, patients that have congenital heart disease have routine blood pressures on all of their exams with the cardiologist, regardless of age. Something to remember is to always check all 4 extremities, at least initially, and make sure that there's not discrepancies, particularly for coarctation of the aorta. Normal blood pressure increases with age, so basically what you'll need to do is look at standard nomograms. I doubt that they'll ask you specific blood pressures. They will maybe give you an example of a patient with a very low blood pressure, and that's easy to diagnose because the numbers will be obviously low. But for treatment's sake, you need to make sure that you know what your standards are, and you can compare that with normal nomograms. It's also important to realize that just because the blood pressure was high once doesn't mean it's always going to be high, so that you need to check the blood pressure on successive days to convince yourself that it is high. Hypertension is divided as essential and secondary. Essential or primary hypertension is not that common in young children. It will be more common as they get older. So an older adolescent, then you can think about essential hypertension. Always remember, in younger children, secondary hypertension should be the first thing you think of, and the most common cause of secondary hypertension in children is going to be renal problems. That means that look for a history of maybe a preterm baby that had an umbilical artery catheterization or umbilical vein catheterization, or look for a child who's had recurrent urinary tract infections or has a history of vesicoureteral reflux or of history of horseshoe kidneys or hydronephrosis. Things. Always look for renal causes in the younger child. Screening tests are listed there, and since we're always looking for renal causes, you should get a urinalysis as part of your workup or screening test. Patients with hypertension, part of their evaluation includes a renal ultrasound to look for the size of the kidneys and look for hydronephrosis, and a plasma renin activity is very helpful. Treatment of hypertension in children is essentially the same as treatment of hypertension in adults. We use basically the same medications.